insulin resistance in type 1 diabetes and latent autoimmune diabetes in adults, or LADA. My name is Kylie Buckner. I'm glad to be here with you today, and we'll get started. Our learning objectives for today are to review the primary dietary cause of insulin resistance and its effect in autoimmune diabetes. We're going to define insulin sensitivity and measure it using the carbohydrate to insulin ratio. We will compare and contrast the conventional dietary recommendations to a low-fat, plant-based, whole food dietary pattern for people living with type 1 diabetes and LADA. We'll explain the effect of increasing protein intake on insulin requirements in autoimmune diabetes, and finally discuss how to successfully help patients transition to a low-fat, plant-based, whole food diet. Just as a brief review of what we covered in Module 3, insulin resistance is a result of the storage of excess fat in tissues that are not designed to store large quantities of fat. And the result of insulin resistance becomes a series of events in the body that disrupt metabolic function. A low carbohydrate or high fat diet will often result in some short-term improvements in blood glucose control, reduction of A1C, potentially some weight loss, and reduction of cholesterol levels and blood pressure. And people with autoimmune diabetes are at risk for insulin resistance when they subscribe to this low carbohydrate dietary approach, as we covered in Module 3. Insulin resistance causes more blood glucose variability in the long term and therefore elevates A1C values and leads to comorbidities of diabetes. So while you may get these short-term improvements of the low carbohydrate and high fat diet, unfortunately, you sacrifice the long-term side effects of creating increased insulin resistance in the muscle, liver, beta cells, and throughout the entire body. And unfortunately, this is what leads to long-term complications and comorbidities in people living with autoimmune forms of diabetes. So what actually is insulin resistance? Insulin resistance will occur when insulin action is decreased. And in past slides, we've reviewed what total body insulin resistance is associated with: high cholesterol, hypertension, increased blood glucose variability, elevated A1C levels, etc. But for people who are living with insulin-dependent diabetes, insulin resistance actually has another significant definition, which is that insulin resistance decreases insulin action. So people who inject insulin who are living with autoimmune diabetes will really struggle when they're in an insulin-resistant state because their insulin action is decreased. It becomes very difficult for them to manage blood glucose values and especially the excursions when their insulin is less effective. So we've talked a lot about insulin resistance, but what is insulin sensitivity? So insulin sensitivity occurs when insulin action is increased, and it's the inverse of insulin resistance. So this occurs when your insulin inside your body, whether it's produced endogenously or administered exogenously, its action is increased. It's more potent, it's more effective inside your body. And achieving an insulin-sensitive state is ideal for all people, but of significant importance for people who inject insulin. When people are living with autoimmune diabetes, they benefit greatly when their insulin works effectively. And when they're in an insulin-sensitive state, the biomarkers for health are in their most optimal state, and there's a reduced risk for chronic health conditions or complications from autoimmune diabetes. So you could look at insulin resistance or insulin sensitivity on a spectrum, where on one end of the spectrum, you see high levels of insulin resistance, and on the other side, you see high levels of insulin sensitivity. And ideally, for optimal health in the long run, you would see people moving towards more insulin sensitive state and gaining insulin sensitivity over time. How is insulin sensitivity commonly measured in the research? There's actually a few different tests that will measure insulin sensitivity, and these typically occur in the research and in clinical settings. So the very first test is the gold standard measurement called the euglycemic hyperinsulinemic clamp. And it's the most accurate test for measuring the maximal rate of glucose disposal into muscle tissue. This test is extremely costly, and it's performed over the course of many hours in a research laboratory with highly trained technicians. So this requires a lot of involvement and is typically a research test. The next test is an oral glucose tolerance test, or OGTT. And this is a test that can be performed in an outpatient healthcare clinic or at a clinical laboratory. The patient drinks a standardized formula containing glucose dissolved in water, and a phlebotomist samples blood glucose and insulin levels in the fasting state and every 30 minutes for 2 hours. The last test is called the frequently sampled IV glucose tolerance test. And this is another complex measurement of insulin sensitivity that must be performed with trained laboratory technicians and measures glucose tolerance intravenously. The problem is that none of these tests are available at home or possible to do independently and require sophisticated laboratory equipment or the help of lab technicians or phlebotomists. So for this reason, a simple at-home measurement of insulin sensitivity is extremely useful so that a patient with insulin-dependent diabetes can understand their level of insulin sensitivity. The ideal test should be sensitive to rapid changes in insulin sensitivity or insulin requirements, and insulin-dependent patients should be able to take this test multiple times per day. So what is a simple at-home measurement of insulin sensitivity? The carbohydrate to insulin ratio. And the measurement of a carbohydrate to insulin ratio becomes the total intake of carbohydrates divided by insulin use. And that's a simple calculation that people living with all forms of autoimmune diabetes or insulin-dependent diabetes can use to measure their level of insulin sensitivity. Now, one thing to keep in mind is that when you're using this measurement, carbohydrate intake and insulin use must be measured over the same period of time. And we're going to talk about the different periods of time that we can measure this in. So the first version of a carbohydrate to insulin ratio is a 24-hour carbohydrate to insulin ratio. And this is calculated by taking your patient's total 24-hour carbohydrate intake and their total 24-hour insulin dosing. So both the combination of their basal and bolus insulin dosing. And you basically divide carbohydrates by insulin and you get a number or a ratio. So for example, if your patient consumes 100 grams of carbohydrates over 24 hours and they inject 25 total units of insulin between basal and bolus dosing in a 24-hour period, then their ratio is a 4-to-1. The carbohydrate to insulin ratio is a 4-to-1. How do you understand or interpret the 24-hour carbohydrate to insulin ratio for people living with autoimmune diabetes? Their 24-hour carbohydrate to insulin ratio will often change from day to day based on their daily activity or potentially the food that they're eating, but it can be tightly managed or controlled with a very systematic approach. One thing to be aware of is that the 24-hour carbohydrate to insulin ratio is suppressed by a low carbohydrate diet, and it's improved or increased by a low fat diet. And this has to do with the level of insulin resistance that your patient is experiencing in the short term and the long term. But there is another measurement of carbohydrate to insulin ratio, and that is the mealtime carbohydrate to insulin ratio. So this is where you take the mealtime carbohydrate intake and divide it by the mealtime insulin use. So this is the bolus insulin only. And this is a really important strategy for people who are living with insulin-dependent diabetes and giving bolus injections at mealtime. If they are able to understand how their carbohydrate to insulin ratio can be affected by variables, including things like hypoglycemic events or added food or added carbohydrate intake, they can more accurately predict their insulin needs at each meal as they begin to increase their total carbohydrate intake throughout the day. So an example of this would be, let's just say your patient eats 50 grams of carbohydrates at their lunch and they inject 5 units of insulin. So that would end up becoming a ratio of 10-to-1. So it's 50 grams of carbohydrate divided by 5 units of insulin. So that's a 10-to-1 ratio. So a 10-to-1 ratio is actually a very common jumping off point for many people who inject mealtime insulin. And it's a much more actual data-driven calculation of how much insulin somebody should take at their meal based on the number of grams of carbohydrate that they're eating. As your patient increases their insulin sensitivity through lifestyle medicine interventions, they will notice that they require less insulin for that same 50 grams of carbohydrate. Now, the question is, how would they know that? What ends up happening is they will have a hypoglycemic event in the 2-hour period following their meal. And the reason for that is the 2 hours post-meal is about this amount of time that their short-acting insulin will be effective. So if they become hypoglycemic in that 2-hour post-meal time frame, it means that they have over-injected or used a ratio that's too low for that meal. When they're hypoglycemic, the treatment for that would be to eat more carbohydrate or glucose to recover from the hypoglycemia. And as they consume more carbohydrate or more glucose in the form of carbohydrate to recover from their hypoglycemic events, they will then calculate a new ratio based on adding the number of grams of the correction carbohydrate to their original mealtime carbohydrate. So let's say your same patient uses that original 10-to-1 ratio and ends up with a hypoglycemic event after their meal. As a correction, they eat 30 grams of carbohydrate to correct for the post-mealtime low blood glucose. So they end up eating 30 grams for the correction plus 50 grams, which was the original meal total, which equals 80 grams total of carbohydrates consumed in that mealtime window. But they still only injected that 5 units of insulin, which they injected at their mealtime. So they take the 80 grams of carbohydrate total divided by 5 units of insulin, and now can calculate a new ratio of 16-to-1. This new ratio of 16-to-1 can be used for future meals, and therefore they would use much less insulin per 50 grams of carbohydrate using the new ratio. The next time they eat a 50-gram meal, if they divide 50 grams by 16, which is the new ratio, they end up delivering 3 units of insulin. And this can continue on and on as your patient continues to gain insulin sensitivity. So therefore, their improved insulin sensitivity leads to overall less insulin injections per grams of carbohydrate and per mealtime. The new ratio can then be applied to future meals and can be readjusted according to continued improvement in insulin sensitivity. So this calculation becomes a very data-driven and specific measurement of insulin sensitivity as your patient reverses their insulin resistance. Your patient's mealtime carbohydrates to insulin ratio is also likely to be different for breakfast, lunch, and dinner. Insulin sensitivity levels can vary throughout the day, and people can gain more sensitivity through the day through different activity they're doing, utilizing their glucose from movement or exercise. And we often see that people do tend to improve their insulin sensitivity throughout the day. The other thing that happens in the morning is that it's common for mealtime carbohydrates to insulin ratio to be lower at the beginning of the day due to the dawn phenomenon. So you could actually see your patient start the day with mealtime ratios of somewhere between 10-to-1 or 20-to-1, but by the end of the day, they could be closer to 40 or 50-to-1. And that means that for every gram of carbohydrate that they're eating, they are using less and less and less insulin throughout the day. The 24-hour carbohydrates insulin ratio is a surrogate metric for your patient's overall insulin sensitivity over a 24-hour period. This is particularly useful for people who may only be using basal insulin dosing or who want to understand their overall insulin sensitivity. The mealtime carbohydrate to insulin ratio is a surrogate metric for your patient's mealtime insulin sensitivity, which is really beneficial in helping patients avoid post-meal blood glucose excursions, either hypo or hyperglycemia. You can start to track this with your patients who are insulin dependent. You will likely see that their ratios will improve very quickly as they reduce their dietary fat and add lifestyle medicine strategies. We'll be talking about clinician strategies for managing autoimmune diabetes when transitioning from a low carbohydrate to a low fat diet. And some of these strategies include supporting your patient in beginning a food logging practice to learn exactly how many grams of carbohydrate they are eating. This type of a practice becomes really powerful for your patient because they can learn the actual grams of carbohydrate they're eating, and they can start to calculate their ratios more accurately. Food logging is a really great way for your patients to become empowered and learn to take the guesswork out of their insulin dosing strategies. You can also start to ask your patients to calculate their mealtime carbohydrate to ratio for breakfast, lunch, and dinner for the first 30 days. When you're starting to apply lifestyle medicine interventions, The first few weeks to the first few months can be a little noisy, and it can be really helpful to start calculating these ratios and writing them down and getting data points for you to help them understand where their insulin dosing is improving as they gain insulin sensitivity. The other thing is you can ask them to calculate their 24-hour carbohydrate to insulin ratio for the first 30 days to gain understanding of their insulin sensitivity improving over the course of time. It also will help you to make rapid changes to their insulin dosing strategy, and we're going to talk a little bit more about that in a few slides. We're going to talk about nutrition therapy and nutrition strategies for people living with type 1 diabetes and compare some of the traditional strategies versus some other options. But first, this is a summary of the goals of nutrition therapy as outlined by the ADA in their consensus statement. And it's really interesting because the ADA recommends promoting healthy eating patterns and emphasizing a variety of nutrient-dense foods in appropriate sizes to improve overall health and improve A1C, blood pressure, and cholesterol levels and aid in maintaining weight. And so when you look at these types of statements, it's really easy to see how a whole food plant-based diet can actually help to meet these recommendations. They also recommend individualizing nutrition needs based on personal and cultural preferences, health literacy, and access to healthy food choices. And when patients start engaging in practices like food logging or understanding their carbohydrate to insulin ratio, this is a way to individualize their nutrition needs and their nutrition goals. They also recommend providing practical tools for day-to-day meal planning, again, making a really great case for food logging to help people understand their meal planning strategies. And then the last suggestion or goal is to focus on matching insulin doses with meal composition through advanced carbohydrate counting. And once again, food logging really makes a powerful appearance here because understanding how many grams of carbohydrate you're eating really allows you to make accurate predictions in blood glucose values and insulin dosing. So in the traditional nutritional approach, the American Diabetes Association public definition of carbohydrates can be very confusing. They have defined carbohydrates as a macronutrient, which we've learned in the previous lesson that there's actually 3 macronutrients: carbohydrate, fat, and protein. And they've defined the types of carbohydrates as starches, sugar, and fiber. And if somebody were to be reviewing this information on the public page, it could be very confusing to understand, well, what is a carbohydrate then? Is it starch? Is it sugar? Is it fiber? And we know that fiber is a component of foods that are rich in carbohydrate energy, so specifically from plant foods. So, and starches become a subcategory of carbohydrate-dense foods, which is more of a subcategory and not really a type of carbohydrate. So nutritionally speaking, this can lead to a lot of confusion for patients when they're reading and consuming this kind of information. And it leads to the belief that the traditional understanding of a low carbohydrate approach is accurate or it should be followed. As we learned in Module 3, not all carbohydrates are created equal, right? That the traditional model is that carbohydrates will spike your blood glucose or spike your insulin levels. And therefore, patients living with type 1 diabetes and LADA tend to have a fear of all carbohydrates. In reality, whole foods and refined or processed foods that are both high in carbohydrate energy are not equal. Whole foods that are not processed do contain fiber and micronutrients that aid in the slowed absorption of glucose into the bloodstream. Refined and processed foods can contribute to more blood glucose excursions because the glucose is more readily available into the bloodstream. So that's why there can be a lot of confusion in the overall world of diabetes about what types of foods or what types of macronutrients to avoid or to eat more of. So as we've learned, insulin resistance is a lipid disorder. Lower fat intake increases insulin action in muscle and liver, and lower fat intake increases carbohydrate tolerance. And it is really important to eat whole foods, not processed plant foods or processed refined foods that are high in carbohydrate value. So when we're talking about a low fat whole food plant-based diet, the low-fat part of the diet will help to prevent and reverse insulin resistance, where the whole food part of the diet will include a combination of macro and micronutrients, which we'll be talking more about in future modules. So what does it mean to be following a low carbohydrate dietary approach in terms of the breakdown of calories and macronutrients from calories? This is a sample day of a low carbohydrate diet, which is an often prescribed strategy in managing type 1 diabetes and LADA. As you can see, the foods that are logged here in this day are equal to about 1,800 calories. There's no recommended caloric intake by either the ADA or any dietary strategies for the management of type 1 diabetes. This is just a sample or example day of a diet that consists of 1,800 calories. But you can see that the foods that are included here tend to be non-plant-based foods. They tend to be much lower in carbohydrate energy. And the reason that we know of that is the breakdown at the bottom right corner of your screen. So you can see the total calories around 1,800, and then you see that the total fat from those calories is 105 grams. And on the left side next to this blue arrow, you see that that equates to about half of their total calories from the day. And the total carbohydrate is around 100 grams, which is the blue bar here to the right. And of the total calories, that equates to less than a quarter of their total energy for the day, leaving the remainder for protein. The foods that are logged on this page are typical foods for somebody who is recommended to eat a low carbohydrate strategy. And as we reviewed in Module 3, the total carbohydrate consumed in this particular day is equal to what we would consider a low carbohydrate diet, or 100 grams of carbohydrate. Now, when we compare this to a sample day of a low-fat plant-based diet, and it's a whole food diet, you see a different strategy. Different types of foods will make an appearance on this daily log. And you see that you still are ending up with 1,800 total calories, but these calories are coming from all whole plant-based foods. And you see fruits and legumes and whole grains and lots of vegetables. And this is a really nice sample of what could be a low-fat plant-based day. And you see that out of those 1,800 calories, carbohydrate energy makes up 370 grams, or a very large percentage of those calories over here on the left side next to the blue arrow. And the total fat for the day is 18 grams. So here's a comparison of those two daily snapshots. So on the left-hand column here, you see low carbohydrate day, and the right column is the low-fat plant-based whole food day. And so the total calories was pretty equal to 1,800 calories. And you see that the total grams of fat went in the low carbohydrate day went from 105 grams down to 18 grams when switched over to a low-fat plant-based whole food day. In the carbohydrates, you see that it went from 100 grams to a very high carbohydrate diet of 370 grams. You also see a significant increase in the amount of fiber consumed for the day. Now, what we've discussed before is that a low carbohydrate diet promotes insulin resistance because, as you can see here, the total percentage of dietary fat is much higher at 52%. As we reviewed in Module 3, insulin resistance is achieved by consuming high amounts of dietary fat. So when consuming a low carbohydrate diet, which is often recommended to people living with type 1 and LADA, you can see that the total caloric intake of dietary fat equates to half of the calories from fat, while the caloric intake from carbohydrate is 18%. Comparing that to a low-fat plant-based whole food diet, which promotes insulin sensitivity, you're swapping the food sources to a diet low in fat and achieving ideal insulin sensitivity and gaining nutrient density and the benefit of the micronutrients like fiber, minerals, vitamins, antioxidants, and phytochemicals. So you can see here that the total grams of fat on the whole food plant-based low-fat version is the total dietary fat is around 10% of total calories, and the total grams of carbohydrate is 75%, which will eventually lead to a higher degree of insulin sensitivity. So one of the measurements that we didn't address was protein. So we are going to talk more about protein and the optimal protein intake. But a common nutritional recommendation in managing type 1 diabetes and LADA is to increase protein. So the question becomes, what is the optimal protein intake? And does autoimmune diabetes change any protein requirements? And as you can see from our comparison diets here, the total grams of protein from the low carbohydrate versus low fat plant-based whole food diet went from 131 grams to 69 grams. How do you know what is the optimal protein intake for your patient? Optimal protein intake is calculated through a simple weight-based calculation. You take your weight in pounds and divide it by 2.2, which ends up achieving the weight in kilograms, and then multiply that weight in kilograms by a range of 0.8 to 1.2. And this calculation can change depending on activity levels or certain metabolic conditions, but overall, this strategy is ideal for most patients. So for example, if you have a patient whose body weight is 160 pounds and you divide that by 2.2, you get 73 kilograms, and multiply that by 0.8 is 58 grams of protein on one end of the spectrum. And then if you multiply that 73 kilograms by 1.2, you get 87 grams. So for a 160 pound patient, their optimal protein intake per day would be somewhere between 58 to 87 grams of protein based on that weight. So you can help your patients calculate how much protein their body actually needs to function properly. And as it turns out, when it comes to adopting a plant-based diet, it's very easy to meet these protein needs. And on the previous slide, we did see that total protein for the day was at 69 grams, which fits into the guidelines for optimal protein intake for the calculation. So scientific evidence suggests that eating significant quantities of both animal protein and saturated fat from animal sources, including dairy, meat, and eggs, is associated with an increased risk of all-cause mortality. As we've covered before, even though low carbohydrate diets can be effective short-term solutions for weight loss, reduced blood glucose, reduced blood pressure, reduced A1C, and reduced triglycerides, the long-term consequences can be far more problematic. So here we have a systematic review and meta-analysis published in 2013 by researchers in Japan that analyzed the results of 17 studies containing more than 270,000 people. They found that people who ate the lowest carbohydrate diets experienced a 31% elevated risk for all-cause mortality or premature death from any cause. Another paper published in 2007 investigated the incidence of cardiovascular disease in Swedish women who ate a low carbohydrate, high protein diet and found something very interesting. They actually assigned a low carbohydrate, high protein score to the diets of these Swedish women shown in each of these 5 columns listed on the screen. What's interesting is that the incidence of all cardiovascular disease increased as the low carbohydrate, high protein score increased, as did the incidence of ischemic heart disease and the incidence of ischemic stroke and the incidence of peripheral arterial disease. These data suggest that as the amount of carbohydrate decreases and the amount of protein increases, the risk of developing cardiovascular disease increases accordingly. Interesting research from the Harvard School of Public. Another paper published in 2007 So here we have a systematic review and meta-analysis published in 2013 by researchers in Japan that analyzed the results of 17 studies containing more than 270,000 people. They found that people who ate the lowest carbohydrate diets experienced a 31% elevated risk for all-cause mortality or premature death from any cause. Another paper published in 2007 investigated the incidence of cardiovascular disease in Swedish women who ate a low carbohydrate, high protein diet and found something very interesting. They actually assigned a low carbohydrate, high protein score to the diets of these Swedish women shown in each of these 5 columns listed on the screen. What's interesting is that the incidence of all cardiovascular disease increased as the low carbohydrate, high protein score increased, as did the incidence of ischemic heart disease and the incidence of ischemic stroke and the incidence of peripheral arterial disease. These data suggest that as the amount of carbohydrate decreases and the amount of protein increases, the risk of developing cardiovascular disease increases accordingly. Interesting research from the Harvard School of Public Health, published in 2010, investigated the difference between animal-based low-carbohydrate diets and plant-based low-carbohydrate diets to determine whether all low-carbohydrate diets are created equal. They discovered something very interesting, which is that low-carbohydrate diets from animal sources were more problematic than low-carbohydrate diets from vegetable sources. Animal-based low-carbohydrate diets increased all-cause mortality risk, but plant-based low-carbohydrate diets decreased all-cause mortality risks. They found something incredibly elegant and incredibly simple, that replacing 2 ounces of chicken breast with 2 medium apples is associated with a 22% decreased risk of premature death from any cause. A recent paper published in The Lancet in 2018 by researchers at the Harvard School of Public Health found something very similar, that animal-based low-carbohydrate diets containing protein and fat sources from lamb, beef, pork, and chicken are associated with increased mortality risk. But the diets favoring protein and fat intake from vegetables, nuts, peanut butter, and whole grain breads are associated with lower mortality risk. So there's similar evidence in the research that shows that low carbohydrate diets that contain protein will increase overall mortality. So the question becomes, does autoimmune diabetes change protein requirements? So there's a common misconception in the world of diabetes that protein stabilizes blood glucose values and therefore should be eaten at every meal in order to avoid a postprandial high blood glucose value. But as we'll see in the upcoming slides, eating more protein can often be more problematic than most people are aware of. Studies performed in people living with type 1 diabetes demonstrate that when 28 to 57 grams of protein is added to a carbohydrate-containing meal, there is a significantly higher blood glucose excursion in the postprandial state that often starts around the 2-hour mark and continues on to 5 hours post-meal. Higher blood glucose excursions lead to higher insulin requirements, causing those with type 1 diabetes to inject significantly more insulin to control their blood glucose. When those same subjects with type 1 diabetes ate a meal containing 75 grams of protein, the results were even more profound. The researchers observed that 75 grams of protein cause a significantly delayed, sustained, elevated postprandial glycemic excursion from 180 minutes to 300 minutes. And that's the red line that you can see across the chart. What's interesting is that it's easy to control blood glucose in the first 2 to 3 hours after eating a meal which is higher in protein, which is why many medical professionals suggest to add protein to a meal to stabilize blood glucose. What this advice doesn't take into account is the delayed onset postprandial hyperglycemia, which then results in a delayed onset postprandial increase in insulin requirements between approximately 3 and 5 hours. Dietary protein does have a delayed glycemic response. And in these charts, in these graphs, you can see that the glycemic response to the standard meal on the left-hand side of the column, which contains 60 grams of carbohydrate, 25 grams of protein, and 13 grams of fat, versus the same meal with an extra 23 grams of fat, which is the middle bar, versus the same standard meal with an extra 23 grams of fat, and the same meal with an extra 50 grams of protein. Panel A in the upper left corner represents the total glucose area under the curve for 300 minutes following a meal. Panel B represents the early glucose area under the curve for the first 150 minutes or 2.5 hours following the meal. And then panel C represents the late glucose area under the curve for 150 minutes to 300 minutes following a meal. As you can see, eating 75 grams of protein at a single meal has the largest glycemic effect during the late postprandial phase between 150 to 300 minutes, and only a minor glycemic effect in the early postprandial phase. Similarly, If you analyze what happens to insulin requirements in people living with type 1 diabetes under the same circumstances, you'll see once again that eating 75 grams of protein at a single meal has the largest insulinemic effect during the late postprandial phase between 150 and 300 minutes, and only a minor insulinemic effect in the early postprandial phase. Researchers from Switzerland have also contributed to this body of research to determine the effect of a single evening meal that's either low in protein and high in fat, or high in protein and low in fat, on the glycemic excursions in patients living with type 1 diabetes while they're sleeping. The purpose of the study was to determine how the macronutrient content of the evening meal affects the ability of a patient with type 1 diabetes to control their blood glucose at night. And the results are similar to the two papers previously mentioned. As you can see in the graph on the screen, the low-fat, high-protein meal elevated blood glucose in the postprandial state starting at approximately 4 hours after the meal began and continuing to 7 o'clock a.m. the next morning, 12 hours after the meal began. The low-protein, high-fat meal also caused a late postprandial blood glucose excursion, although less than the meal containing a higher protein content. The take-home message is that both a high-fat and a high-protein meal can elevate blood glucose in a delayed manner, and researchers tend to agree that the high-protein meal has the strongest effect. Australian researchers published a paper in 2013 to determine the effects of both protein and fat on postprandial blood glucose excursions in children living with type 1 diabetes. The bottom glycemic response corresponds with a meal containing 30 grams of carbohydrate, 4 grams of fat, and 5 grams of protein. Keeping the carbohydrate and fat content the same and selectively increasing the protein content to 40 grams increases the blood glucose excursion. Keeping the carbohydrate and protein content the same, but increasing the fat content to 35 grams increases the blood glucose excursion even more. And finally, keeping the carbohydrate content the same, but increasing both the fat content to 35 grams and the protein content to 40 grams causes the highest glucose excursion. The take-home message from this paper is simple. Increasing both the fat and protein content of a meal can each elevate postprandial blood glucose concentrations in isolation, but most importantly, when 30 to 40 grams of protein and fat are both eaten in the same meal, the glycemic effects are additive, resulting in the highest glycemic excursion. There's some evidence to show that low-fat plant-based whole food nutrition may also preserve beta cell function in the early stages of autoimmune diabetes. We briefly discussed this in Module 3, and this specifically pertains to people living with LADA. So as the degree of insulin resistance increases, you move from a normal islet function towards beta cell suicide. So beta cell death can occur as a result of beta cell insulin resistance. And when that's combined with the dysfunction of beta cells from the autoimmune form of LADA, then you end up with a double effect of loss of beta cell function. When you give the beta cells the ability to improve their insulin sensitivity, or you take away the insulin resistance of the beta cell through lifestyle medicine strategies and reducing dietary fat, improving insulin sensitivity means that you may actually preserve islet cell function for longer periods of time. And that can help people living with LADA to preserve their own endogenous insulin production for a longer period of time. We're going to compare a little bit about the dietary strategies and dietary patterns that have low versus high nutrient density, kind of pulling together what we've talked about in terms of the percentages of calories from different macronutrients. So how do these diets compare overall in terms of long-term chronic disease risk? What you see here is 3 dietary strategies. One is a low or very low carbohydrate diet, which is low in carbohydrate, high in fat, and pretty high in protein. When you look at the middle column, you see a diet that resembles more of the standard American diet, which is a moderate carbohydrate dietary approach with 40% carbohydrate, 40% dietary fat, and 20% of calories coming from protein. And then the last column, which is a low-fat plant-based whole food diet, where you've switched the density of carbohydrate to a higher percentage and a lower percentage of dietary fat and protein. In the middle, you'll see that diets that are moderate in carbohydrate and moderate in dietary fat will produce the outcomes of high chronic disease risk. On the left, the low carbohydrate or very low carbohydrate approach will potentially give you outcomes like flatline blood glucose, but they promote insulin resistance and they are associated with a high degree of chronic disease risk. On the right-hand side, you see that in the whole food, carbohydrate, low dietary fat approach, you'll see much better controlled blood glucose, more insulin sensitivity, and a much lower degree of chronic disease risk. The question becomes, how do you start to help on the right-hand side, you see the question becomes, how do you start to help your patients to move toward a low-fat plant-based whole food diet to maximize their insulin sensitivity and increase their total carbohydrates and as they're decreasing their dietary fat? So one of the best places to start is understanding the categories of food that are low in fat versus high in fat. So we have constructed a very simple traffic light system that helps you to categorize food for your patients. And one of the easiest ways to do this is to look at optimizing or maximizing green light foods. So under the green light category, you see fruits and all vegetables, beans, lentils, and legumes, intact whole grains, herbs and spices and mushrooms. The yellow category contains foods like nuts and seeds, avocados, coconuts, olives, and then some of your more refined foods that these foods are often still high in fiber and nutrient density, but they tend to be higher in fat. So when we're talking about reducing dietary fat, these foods are foods to be eaten in moderation. And then the red light foods are foods that are much higher in dietary fat. They contain animal proteins, and these are foods that are highly refined and highly concentrated in fat and refined sugars, and more processed foods live in this category. So as you're starting to think about constructing the conversations with your patients, simply bringing their attention to categorizing food can be a really great strategy. And as your patients, especially your patients living with autoimmune forms of diabetes, are starting to gain awareness that they can begin to modify their dietary strategy, giving them simple instructions can be really helpful in starting out a lifestyle change process. One thing to keep in mind for your patients living with insulin-dependent diabetes is that rapid dietary transitions towards more green light foods and lowering dietary fat can cause severe hypoglycemia, and that can actually happen very, very quickly. So patients who get really motivated to make dietary changes, when they make those full-on dietary changes and reduce their dietary fat very quickly, they will see a very quick reduction in insulin needs. And over the course of a few months or even a few weeks, you can expect to see a 20 to 60% reduction in basal insulin and a 20 to 60% reduction in bolus insulin dosing. So as people start to make adjustments to their food, it can be easy to have a step-by-step approach because lifestyle change isn't always an easy thing to undertake. So when patients have a very simple strategy to make one change at a time, it can help them to become more compliant and also gain more confidence with their lifestyle strategies. And with people living with insulin-dependent diabetes, when you make adjustments to your meals slowly, it allows a gradual decrease in insulin resistance, which helps to prevent rapid decline in blood glucose levels. So, for example, somebody who makes a step-by-step approach, as outlined here, will see a much slower and more gradual reduction in insulin requirements, which also helps them to prevent hypoglycemic events. And when your patients are adopting a low-fat plant-based whole food diet, preventing hypoglycemia becomes a primary strategy because they gain insulin sensitivity very quickly when eating whole foods that are low in fats. managing insulin dosing becomes a really important part of their strategy. And oftentimes, patients feel scared because they become hypoglycemic and also don't know how to make the adjustments to their insulin dosing. So, taking this step by step approach, your patient can adjust their meal time carbohydrates insulin ratio slowly, which also helps to prevent overwhelm in making lifestyle changes. So, the very first step is to change breakfast. And we're going to talk a little bit more about these specific meal changes, but changing breakfast first often, again, helps to build confidence, helps to start the day out in a really positive way. And eventually, once the first meal change is made, then it becomes easier to then change lunch, change dinner, adjust their snacks. And then eventually, adding strategies like intermittent fasting to test the basal rate and adjust basal dosing will be a really important part of the strategy in understanding total insulin needs. And then finally, if your patient doesn't already have exercise included in their daily lifestyle strategies, adding exercise as a lifestyle modification can then also help to gain additional sensitivity, but they'll have already made adjustments to their breakfast, lunch, and dinner. So it won't be quite as overwhelming to understand which variable is affecting their insulin sensitivity. Step 1 involves eating more green light foods, which in turn reduces the total dietary fat intake. So the very first part of this, as you decrease total dietary fat, actually helps to make room for more glucose inside the cells. So reducing dietary fat can come in the form of avoiding things like oils or other animal proteins or other animal foods. And that's something that you can educate your patient about, especially reducing oil or eliminating oil altogether. That's one very easy change that people can make to reduce total dietary fat. And as they're reducing their dietary fat, they make more room for glucose as they reverse insulin resistance. So step 2 becomes gradually increasing carbohydrate intake. And again, people living with insulin-dependent diabetes, either type 1 or LADA, often tend to have a little bit of a fear of adding more carbohydrate. So they tend to prefer to increase their carbohydrates slowly anyway. So they may start out with, for example, 25 or 35 grams of carbohydrate per meal, and starting out lower helps them to gradually move up to upwards of maybe 75 or 100 or 150 grams of carbohydrate per meal in the long term. So helping your patient to see where they're going with their dietary strategy is a really strong intervention you can help make to show them that while they may be still eating a lower carbohydrate strategy, they may start out with, for example, 25 or 35 grams of carbohydrate per meal, and starting out lower helps them to gradually move up to upwards of maybe 75 or 100 or 150 grams of carbohydrate per meal in the long term. So helping your patient to see where they're going with their dietary strategy is a really strong intervention you can help make to show them that while they may be still eating a lower carbohydrate strategy at the beginning, eventually the goal could be to be at a much higher carbohydrate intake from whole foods. And showing them where they're going with their dietary strategy and interventions can be really, really helpful so they understand how to start adding more carbohydrate over the course of time. Step 3 involves monitoring blood glucose values. So as you're reducing dietary fat and increasing carbohydrate, insulin sensitivity starts to respond really quickly. So monitoring blood glucose patterns becomes really important. Many people living with insulin-dependent diabetes do use CGM technology, and that can be really useful in helping to monitor your patient's blood glucose. But overall, you'll start to see a decline in blood glucose values overall, and also you'll start to see less variability between meals, overnight, and in between activities like exercise. So as fat continues to decrease, as carbohydrate continues to increase, you will start to see improved blood glucose patterns overall. And step 4 becomes reducing insulin use in response to reduced blood glucose. So as your patients start to notice that their blood glucose is reducing, you will be able to help them navigate reducing their insulin, whether it's through recalculation of their carbohydrate to insulin ratios or through overall reduction of total basal dosing. People living with type 1 diabetes and LADA who inject insulin will experience reduction in insulin use as a result of lowering their dietary fat and increasing their total carbohydrates from whole foods. So here are some guidelines that we use when working with our clients in adopting a low-fat, plant-based whole food diet and helping them gain maximum insulin sensitivity. This is a very simple way of giving your patients some guidelines around how much energy to consume from carbohydrate food versus other macronutrients. So we recommend eating a minimum of 70 to 80% of carbohydrate from whole plant foods, eating a maximum of 10 to 15% of fat from whole plant foods, eating a maximum of 10 to 15% of protein from whole plant foods, moving your body or sweating for 30 to 60 minutes per day, using intermittent fasting when necessary to check basal dosing, and also joining a community of other people who are also involved in lifestyle change and using lifestyle medicine interventions for inspiration and commitment and accountability. When you're instructing your patients to utilize lifestyle medicine strategies, it can be a little overwhelming for some patients. And some patients will even feel that they aren't sure how to approach that. So giving them resources of support and community, giving them support on how to make these changes is a very strong intervention that you can make as a provider. So when it comes to people who inject insulin living with autoimmune diabetes, one of the challenges that can occur when adopting a low-fat plant-based diet is hypoglycemia. And so having that conversation with your patient about how to manage hypoglycemia can really help to mitigate the stress or complications of hypoglycemic events. So recognizing that hypoglycemia can occur and often results from rapid improvements in insulin sensitivity is the first part. Just letting your patient know that as they start making dietary adjustments, they're going to need to reduce their insulin levels and insulin dosing. So that is needed in both their carbohydrate to insulin ratio and basal dosing. Remind your patients to stay prepared with correction foods of 15 grams of high fiber carbohydrate. So foods like fruits, like apples, bananas, and dates are really great foods to have on hand in case they do become hypoglycemic at any point during the day or night. The high fiber recovery snacks help to minimize that post-correction roller coaster of correcting lows by stabilizing blood glucose elevation. So as we've talked about before, fiber can actually help slow down glucose uptake. So eating whole fruit can make a big difference in the post-recovery process if you're correcting for a low blood glucose value. And the other suggestion for patients is to try not to overcorrect with more than 15 grams of whole food carbohydrate. That can actually cause higher blood glucose values, which end up requiring more insulin dosing, and it ends up putting patients on a roller coaster ride of blood glucose corrections. The other support you can offer your patient is to encourage them to become proactive in their insulin dosing. So teaching them how to readjust their carbohydrate to insulin ratios and how to adjust their basal dosing strategy when they notice their blood glucose values dropping. There are some common patient objections to adopting lifestyle changes or making changes in dietary strategies. So some things that you may hear from your patients is that eating a plant-based diet is too hard, or I don't know how to get started. Another thing that you may hear is that they're scared that carbohydrates will spike blood glucose and insulin use, and that may be something that they've experienced in the past. Some patients are scared of exercise out of a fear of hypoglycemia, and other patients are not confident in making changes to insulin dosing. So again, giving them some tools and strategies for helping to mitigate some of these objections can be really supportive. Some support you can offer your patients when they're having some of these objections is first and foremost to change just one meal at a time, starting with breakfast. And breakfast is a really easy place to start because it's the first meal of the day and it starts the day off in a positive direction. When you help your patient focus on eating 100% whole foods for one meal out of the day, it can help to create a dietary pattern that will be more likely in the whole food category. Also, giving your patient permission to eat fruit is a really great strategy. Many patients living with type 1 diabetes or LADA are scared to eat fruit. They've been told in the past that fruit is not a great food choice for them because it will raise their blood glucose values. And letting them know that fruit is rich in fiber and nutrients that are going to help to reverse insulin resistance will actually be really encouraging for them. And oftentimes they just need to hear that permission to go ahead and eat fruit. Another really great strategy is to focus your patient on eating fiber-rich foods. Talking about the benefit of adding more fiber to meals can help to decrease the overwhelm of changing a diet to a certain style of diet, like, plant-based or whole food plant-based diet. Sometimes just not understanding the dietary strategy up front can be overwhelming for patients. So when you just have them focus on fiber-rich foods and the benefit of fiber in their diet, that can sometimes help to prevent that overwhelm that can come with changing diets. And also teaching your patient how to adjust their carbohydrates insulin ratio as their insulin sensitivity improves can be really, really powerful. It gives them the power to make changes so that they won't have as much fear of hypoglycemia. So addressing blood glucose spikes and insulin timing is another strategy that you can help your patient to overcome some of the objections. So educating your patient on the importance of injecting bolus insulin 15 minutes before eating their meal is a really great strategy, especially when the meal is higher in carbohydrate. It allows the insulin to be inside the bloodstream and inside the system when the glucose comes on board. So there's a less rapid elevation of blood glucose because the insulin is already waiting in their body for them when they start eating their high carbohydrate meal. Another way to address post-meal blood glucose elevations is to recommend beginning eating the meal once blood glucose values have reached 120 and are trending down. So when the levels of blood glucose are less than 120 and you eat a carbohydrate-rich meal on top of that value, it helps to minimize the total elevation. So if a patient's blood glucose is less than 120 before a meal, it may reach up to the 180 or 200 post-meal, as opposed to starting with a blood glucose range of 150 or 180 prior to the meal. They may end up over 200 after a meal. So pre-meal values matter when it comes to the post-meal area under the curve. And that can also influence total A1C values. So starting meal time with a blood glucose in range and below 120 is a really, really powerful strategy for people living with autoimmune diabetes. Another suggestion for your patients is to eat their food slowly. Eating slowly over 30 to 45 minutes can really make a difference in the glucose absorption. And we see this continually on CGM patterns. You can observe that from your own patients' CGM patterns. You can challenge them to break their meal up a little bit and eat their meal slowly over 30 to 45 minutes. And you can watch on the CGM pattern how the blood glucose curve is not as elevated as it would be if they're eating their meal very rapidly. The last suggestion is to add raw greens to meals to slow the glucose uptake. And that's because raw greens contain a dense proportion of fiber and water, which help to minimize glucose uptake or slow down glucose uptake after a meal. The next step is adding exercise in, and adding exercise, especially post-meal, can actually act as a substitute for insulin. And we're going to talk a little bit more about that. Exercise promotes non-insulin dependent glucose uptake in muscle tissue during and after exercise, which increases the amount of glucose that can enter the muscle tissue from the blood independent of insulin. Under normal circumstances, insulin binding to the insulin receptor on the membrane of a muscle cell will trigger a signaling cascade that translocates GLUT4 vesicles to the cell surface to allow glucose to enter the cell. Exercise has a very similar effect in that it can trigger the movement of GLUT4 vesicles to the membrane to allow glucose to enter the cell. So you can think of exercise as a substitute for insulin because both exercise and insulin allow glucose to enter muscle cells and mass. Exercise will increase insulin sensitivity during exercise, and peak insulin sensitivity is often achieved during exercise. From the time exercise is finished, insulin sensitivity begins to decline. And the phase 1 afterburn is a period of time that lasts approximately 3 hours in which glycogen synthesis enzymes in the muscle are at peak activity and insulin sensitivity remains high. The phase 2 afterburn is a period of time beyond the 3-hour mark where insulin sensitivity is still decreasing and returning to baseline levels. There are 3 main types of exercise: cardiovascular exercise, resistance exercise, and combination exercise. Exercise will increase insulin sensitivity during exercise, and peak insulin sensitivity is often achieved during exercise. From the time exercise is finished, insulin sensitivity begins to decline. And the phase 1 afterburn is a period of time that lasts approximately 3 hours in which glycogen synthesis enzymes in the muscle are at peak activity and insulin sensitivity remains high. The phase 2 afterburn is a period of time beyond the 3-hour mark where insulin sensitivity is still decreasing and returning to baseline levels. There are 3 main types of exercise: cardiovascular exercise, resistance exercise, and combination exercise. And these exercises can be performed at different times to help improve insulin sensitivity, but also to utilize glucose and increase glucose uptake into the cells. So cardiovascular exercise, resistance exercise, and combination exercise can be used by your patients every day to help to improve their insulin sensitivity in the short term and in the long term. One of the fears that people living with insulin-dependent diabetes often have is the fear of hypoglycemia after exercise or with exercise. And there are some strategies that you can help your patients to adopt to safely add daily exercise, especially as they're gaining insulin sensitivity. So with increased insulin sensitivity comes the potential for more glucose excursions or hypoglycemia with exercise. So one of the things that your patient can do is actually begin exercise with a blood glucose value that's between 150 milligrams per deciliter and 180 milligrams per deciliter. So that range is a good place to start, meaning that the meal before they eat, maybe they want to allow their blood glucose to rise just a little bit before they perform exercise. So they can either use less insulin at mealtime to achieve a higher blood glucose post-meal, or they can eat something prior to exercise to bring their blood glucose into that range. And what happens is that as they're exercising, they're utilizing the glucose, their insulin sensitivity is improving, and they end up lowering gradually their blood glucose down into range without becoming hypoglycemic. The American Diabetes Association consensus statement on strategies for managing type 1 diabetes does include incorporating daily exercise, and 30 minutes of exercise per day is recommended for people in general to improve their long-term health and reduce their risks of cardiovascular disease. So 30 minutes of exercise per day can really help with improving insulin sensitivity as well as meeting the guidelines put forth by the American Diabetes Association in their consensus statements. One strategy to add in is to exercise in the morning hours to help to counteract the dawn phenomenon, and also that it helps to promote insulin sensitivity in the morning hours so that if blood glucose values start to drop throughout the day, your patient will still be awake in order to adjust or correct for any low blood glucose. And the last thing is your patients would benefit from being as consistent as possible. So performing exercise in multiple consecutive days has a very strong effect on insulin reduction as well as improving insulin sensitivity. Another step or another intervention, one of the fears that people living with insulin-dependent diabetes often have. Another step or another intervention that you can help your patient with is understanding what causes situational insulin resistance. And this is something that impacts many, many people living with type 1 diabetes or LADA. And people who inject insulin can really relate to this type of situation. And it's something that we work with our clients to understand about their blood glucose variability. Situational insulin resistance occurs when you have high blood glucose values that feel unexplained or random. So there's really no clear correlation to what may have caused that level of blood glucose variability. And this can often be caused by things like viral infections or bacterial infections, stress. One really high fat meal can cause this. Hormonal changes like menstruation or ovulation or pregnancy can cause situational insulin resistance. And even things like changes in elevation or dehydration or temperature changes can also lead to situational insulin resistance. And maybe you've heard your patients talking about this. One of the common things that we hear is that patients will say, or clients will say, it feels like my insulin's just not working. And that leads to what is termed situational insulin resistance. So how do you troubleshoot situational insulin resistance? So one of the things that your patients can do is to be consistent in eating a low-fat, plant-based whole food diet as much as possible. So really lowering their dietary fat, increasing their calories from whole foods, plant-based foods that are high and rich in nutrients and fiber can be very, very supportive. Also, prioritizing walking for 30 minutes after each meal can help with that glucose utilization. Applying stress reduction techniques and other lifestyle medicine strategies to help them ensure adequate sleep and improve their overall well-being can be really useful in troubleshooting insulin resistance, especially situational insulin resistance. So, what can you expect to see in your patients living with autoimmune diabetes who are gaining insulin sensitivity as they adopt these lifestyle strategies to improve their insulin sensitivity? You'll see lower A1C. You will see a reduction in their overall insulin use and an improvement in their carbohydrate to insulin ratio. You'll see lower cholesterol levels, lower blood pressure readings, improved energy, and better sleep. And this is very repeatable, and you will start to see this happening very quickly with people who are injecting insulin. So we have a few case studies to review. So what can you expect to see in your patients with people who So we have a few case studies to review here of people who have applied these strategies, applied this approach, adopted a low-fat, plant-based whole food diet, and have been living with autoimmune diabetes. And I'm just going to review this first one. So this is somebody who was living with type 1 diabetes for 15 years. And this person was following a low-fat, plant-based dietary approach for 1 year. So after a year, the results were that this person achieved a 35-pound weight reduction. They reduced their insulin use by 50%. They increased their carbohydrate intake to 400 grams per day. This means that she increased her insulin sensitivity by 566%. Over the course of the year, her A1C decreased from 7.1% to 5%, which is the lowest that it ever was in her life with type 1 diabetes. So in 15 years, she never saw an A1C that low. And the beauty of this is that this person is now eating bowls of fruit for breakfast, beans and rice and vegetables for lunch, steamed broccoli and roasted vegetables, and whole grains for dinner. They really love the food that they're eating. They feel great. And this is a really wonderful testimony of somebody who has made these dietary adjustments and learned how to reduce insulin, and improve their overall health markers. This is another case study of someone who is a 28-year-old person living with type 1 diabetes. They were diagnosed at 12 years, so living with type 1 diabetes for 16 years. Prior to making any modifications, they were following a standard diabetes dietary approach with a moderate carbohydrate intake. But at 28 years old, this person developed diabetic nerve pain and hypertension and had an elevated A1C. They adopted a low-fat plant-based dietary approach with increasing carbohydrate energy, and their overall carbohydrates insulin ratio improved from a 5-to-1 to a 20-to-1 over the course of a few months. So that's a huge overall ratio improvement, meaning that for every gram of carbohydrate, they were using far less insulin per gram of carbohydrate. And here's a little summary of the biomarkers that this person shared with us. And over the course of 6 months, the dietary carbohydrate in grams per day went from 300 to 400 grams per day to 500 to 600 grams per day. And their dietary fat changed from 150 grams per day down to 50 to 75 grams per day. Total insulin injected went from 70 to 80 down to 20 to 30. So significant reduction in insulin use right there. Their fasting blood glucose improved from the 180 to 280 range to 72 to 145. So really having an in-range fasting blood glucose value overall. And A1C improved from 8. And this is just a statement from this person. Overall, I feel so much better. I have way more energy now. My chronic pain from old injuries is diminishing and the injuries are healing. Neuropathy is pretty much healed. They reported that their kidney stones were either dissolved or passed. Circulation to hands and feet has improved drastically. Their gut microbiome went through a healing period and digestion improved. Mental health and clarity is now as good as it ever has been, and they're enjoying every day with their new lifestyle. So really just that there's so many benefits of a plant-based diet, but seeing that somebody living with type 1 diabetes for 16 years can improve and heal their neuropathy pain, their circulation to their periphery, as well as improved digestion is a huge outcome for people living with type 1 diabetes who potentially could fear long-term complications of living with type 1 diabetes. This is another incredible case study of somebody who is a 27-year-old living with type 1 diabetes for 16 years. This person was following a low carbohydrate dietary approach and at that time was eating 25 grams of carbohydrate per day. They'd been instructed to follow a low carbohydrate diet and they were trying to be compliant with that. And at the time, they were using 22 units of insulin, meaning a 1-to-1 carbohydrates insulin ratio for meals. So for every gram of carbohydrate, they were injecting 1 unit of insulin. Also, this person developed high cholesterol and at 27 years old had developed stage 3 chronic kidney disease and was very scared. She was scared of her short and long-term outcomes, but she was very scared of requiring things like dialysis or kidney transplant. So she changed her diet to a low-fat plant-based whole food diet with a high carbohydrate dietary approach. So went from 25 to 200 grams of carbohydrate per day. She decreased her insulin to 11 units total per day and went from a 1-to-1 carbohydrates to insulin ratio to an 18-to-1 carbohydrates to insulin ratio. Her cholesterol improved to 112 and her kidney doctor put her in remission for chronic kidney disease. So her stage 3 kidney disease was in remission. And so as a result, she has really gotten her life back. She's a young woman who was very happy to have her life back so she could optimize and maximize her life with her family and her children. And this is a really great testimony of the power of a low-fat plant-based whole food dietary approach for people living with type 1 diabetes. In summary, though, more research is absolutely needed in the world of autoimmune diabetes and the nutritional approaches, especially like the one that we have discussed here. People living with autoimmune diabetes benefit from reversing and preventing insulin resistance because it decreases their risk for all-cause mortality and allows them to manage their blood glucose in a very positive way. And in my experience working with people living with type 1 diabetes and LADA, I have found that people living with autoimmune diabetes are very open to making changes, and especially when they're supported by their doctor, or healthcare provider, they become even more motivated. I used to really underestimate people's willingness to change as a person in the healthcare world myself. And now I see that when people are given the right tools at the right time and the support needed to make health-based changes, they're very willing and able to make those changes. And they especially succeed when they get the support from their healthcare team and their healthcare providers. So in summary, we have reviewed the primary dietary cause of insulin resistance and its effect in autoimmune diabetes. We've defined insulin sensitivity and how to measure it using the carbohydrate to insulin ratio. We've compared the conventional dietary recommendations to a low-fat, plant-based, whole food dietary pattern for people living with type 1 diabetes and LADA, and explained the effect of increasing protein intake on insulin requirements in autoimmune diabetes. And finally, we discussed how to successfully help patients transition to a low-fat, plant-based, whole food diet. I thank you so much for being here and for your attention to this material and information. I hope that you're able to apply this information to your patients living with autoimmune forms of diabetes to improve their glucose control while improving their long-term health.